Hi everyone, this is Abby, PGY2 Oncology Pharmacy resident. And for today's Clinical Pearl, I'm going to be talking about some guideline updates from ASCO, or the American Society of Clinical Oncology, in regards to dosing oncology medications in the obese patient population. So as I mentioned, we have new guidelines. The last guidelines that were published by ASCO in terms of discussing dosing within the obese patient population, they were published in 2012. And in the past decade, we have definitely had a lot of change and a lot of new medications that have been added to the oncology landscape. As always, a lot of this dosing is talking about BSA, or body surface area, which when I think about it, usually when I'm looking at a BSA and doing calculations, typically this is going to be close to 2. Now, if I calculate something for a patient who is really, really small, or for a patient who is larger, this can vary a bit, but just in clinical practice, it seems that usually this BSA value is going to land somewhere in that 2 range. Now, there's a lot of different thoughts about in the patient population that's considered to be obese. If we do increase the dose for, let's say, a BSA that does come out to closer to 3, are we just going to increase toxicity for those patients? And should we do some form of a dose capping method? However, in recent literature and more literature that has come out, it does support dose capping does lead to inferior outcomes, specifically for those obese patients. Now, looking at just a little bit of history for BSA equations, the most common that we use include the Dubois and the Mosteller equations for BSA. And if we look at this was validated back in a time in the 1940s and 50s. And, as we know, back in that time, we were not as obese as we are now. So that is a good question if these BSA equations do have validity within the current times that we're in. And it is recognized that there is some failure with these medications or these equations when patients are really tall, really small, really heavy, or really tiny. And we are going to have some distorted values that we could see. Of note, and this is an actual quote, there are ongoing efforts to establish a new BSA equation suitable for the 21st century. The new title of these guidelines from ASCO are Appropriate Systemic Therapy Dosing for Obese Patients with Cancer. ASCO Guideline Update. The purpose of these new guidelines are to provide recommendations for appropriate dosing of systemic anti-neoplastic agents in obese patients with cancer. The methods that the authors utilized include a systematic review of literature that was collected regarding dosing of chemotherapy, immunotherapy, and targeted therapies in obese adults with cancer. They looked at PubMed and also the Cochrane Library, and they queried data from November of 2010 to March of 2020. And they were able to include 60 total studies in formulating their recommendations for the new guideline updates. Obesity is recognized as standard in other guidelines and literature as a body mass index, or BMI, of greater than or equal to 30 milligrams per meter squared. Between 1999 and 2018, the age-adjusted prevalence of obesity in the United States for adults has increased from 30.5% to 42.4%. As I mentioned in a prior slide, the original ASCO update was published in 2012, and this focused on cytotoxic chemotherapy. However, since that time, there have been multiple novel cancer therapies, including immune checkpoint inhibitors, targeted cancer therapies, and other therapies that have come to the market that we are using very frequently in our patients for cancer treatment. Now, these guidelines are really nice in that they are formulated in 6 clinical questions where the authors answer those 6 clinical questions and then also provide literature to support those recommendations. So throughout the rest of this Pearl, I will be going over those 6 clinical questions and also the recommendations of what practitioners should be following at this time. For clinical question 1, this states, what are the safety and efficacy of full weight-based dosing of cytotoxic chemotherapy in obese patients with cancer? And the recommendation provided within the ASCO Guidelines states that full weight-based dosing of cytotoxic chemotherapy should be offered regardless of obesity status. Now, this is an evidence-based recommendation with an evidence quality that is low, and the strength of the recommendation is moderate. Now, if there is something that I did glean from reading these guideline updates, it is really that dose capping for the obese patient population does lead to inferior outcomes for patients with cancer. And therefore, this first clinical question that they talk about really addresses that head on and does state that we should be dosing patients full dosing regardless of their obesity status or their BSA. Clinical question 2 of the guidelines states, is the use of fixed dosing, dose prescribed independently of weight or BSA, cytotoxic chemotherapy, ever justified? Are there unique dosing considerations for certain chemotherapeutic agents? Now, the recommendation for clinical question 2, the panel recommends limiting fixed dosing of chemotherapy to select cytotoxic agents. For example, they list bleomycin. Although fixed dose of other cytotoxic chemotherapeutic agents has been used in clinical trials, evidence remains limited that fixed dosing strategies are equivalent to weight or BSA-based dosing in terms of toxicity and efficacy. Now, this type of evidence is evidence-based. The quality of the evidence is low, and the strength of the recommendation is, again, moderate. Clinical question 3 of the guidelines. What are the safety and efficacy of approved doses of checkpoint inhibitors, fixed or weight-based, in obese adults with cancer? Recommendation 3 includes that FDA-approved prescribing information for checkpoint inhibitors should be used in all patients, regardless of obesity status. Now, this type is evidence-based, evidence quality is low, and the strength of the recommendation is moderate. Now, I think we all can understand, or at least have seen in clinical practice, that we should be following the FDA-approved dosing for any type of agent. However, with some of our immune checkpoint inhibitors, like pembrolizumab, for example, this is a fixed dosing, either every 3 weeks or every 6 weeks. And then some of our other immune checkpoint inhibitors do have a weight-based dosing. So a lot of this really does come down to how those individual PK parameters were studied in those initial trials, and then how those are adopted within clinical practice. Clinical question 4 is very similar to clinical question 3, but just in the sense of targeted therapies. Should we be using a fixed or weight-based dosing in obese patients with cancer? And the recommendation is, again, very similar to what we saw with clinical question 3, where FDA-approved prescribing information for targeted therapies should be used in all patients, regardless of the obesity status. This is an evidence-based recommendation, the quality is low, and the strength of the recommendation is moderate. For clinical question 5, if an obese patient experiences high-grade toxicity, should systemic anti-neoplastic therapy doses or schedules be modified differently from modifications used for non-obese patients with cancer? And the recommendation from the guidelines states that if an obese patient experiences high-grade toxicity from systemic anti-neoplastic therapy, Clinicians should follow the same guidelines for dose reduction for all patients, regardless of the obesity status. The type is an information consensus, the evidence quality is insufficient, and the strength of this recommendation is weak. Looking within the guidelines for this clinical question, there is a lack of published literature talking about dose reductions in obese patients who do experience toxicity. So that is why the strength of the recommendation is so weak. And really, we have a lack of literature that supports varying dose reductions for each agent, regardless of body habitus or how large or small the patient may be. And finally, for the last clinical question that is addressed in the new ASCO Guidelines, clinical question 6, this one states, how should BSA be calculated? Specifically, what is the best formula for use with an obese patient with cancer? And the recommendation states that the panel recommends that BSA be calculated using any of the standard formulas. There is no evidence at this time to support one formula for calculating BSA over another. And as I previously mentioned, maybe this recommendation will be changing in the future if there is a new BSA calculation or equation that is more suited for our obese patient population. Currently, this recommendation type is evidence-based, the evidence quality is low, and the strength of the recommendation is moderate. The guidelines do end with a really great discussion of a couple different topics listed here. I do encourage all of you to read the guidelines. They're not very long, but they do offer a really great review of some of the different compelling literature that supported all of those recommendations that I provided for you. Obviously, in this clinical pearl, I didn't have time to go over each of the individual trials that supported those recommendations, but those are really nice to read and really give you an understanding of where these recommendations are coming from. Finally, to highlight some of the different pieces that are discussed in the final portion of the guidelines, these include clinician and patient discussions. So if a patient who is obese is experiencing toxicity from a certain chemotherapy regimen, it is important to look at that individual patient and look at their individual case and really come up with a plan that best serves their needs. Also, it's important to recognize that even though they were able to pull 60 different studies, there is still a lot of limitations of research and limitations of published data that we currently have addressing this topic. Also kind of interesting to think about are different health disparities and multiple chronic conditions that different patients might have when you're looking at a patient who is obese undergoing chemotherapy. For example, they talk about, do you avoid or do you dose cap an anthracycline, for example, for fear of patients having cardiotoxicity if they are obese? As we know, patients who are obese are more predisposed to have adverse effects on their cardiovascular system. So is just simply being obese causing issues with that cardiotoxicity? Or is it more pronounced with an anti-neoplastic agent? So again, kind of a lot of different clinical pictures and clinical scenarios that we have yet to fully understand and elucidate just quite yet from these guideline updates. Thank you all so much for listening to today's Clinical Pearl. If you have questions, you can always email me at aferdinand@monument.health. Thank you.